Hi, my name is Nick Johnson, and I'm a principal and consulting actuary with Milliman. I'm pleased to welcome you to this training on what Medicaid officials need to know about Medicare Advantage contracting and bid development. This training module is part of a Medicare Advantage Policy Basics video series developed by the Center for Healthcare Strategies with funding support from Arnold Ventures, the Commonwealth Fund, and the SCAN Foundation. The goal of the Medicare Advantage Policy Basics video series is to support Medicaid and partner agency staff as they build needed Medicare capacity. Many states are focused on improving care delivery for individuals duly eligible for Medicare and Medicaid. State Medicaid agencies focused in this area are increasingly using state contracts with dual eligible special needs plans, or DSNPs, to advance their related goals. For state officials either actively working with DSNPs to advance integration or just beginning to consider how to best contract with DSNPs, it's essential to understand how the federal Medicare Advantage program works. So each of the training videos in this series begins by introducing foundational Medicare knowledge before reviewing some of the policy and program design opportunities that are available to states. The trainings also cover why particular features of the Medicare Advantage program matter to state Medicaid and partner agencies working with DSNPs. Finally, they highlight where viewers can find additional resources and support to learn more. Now let's review what we will cover today on Medicare Advantage contracting and bid development. We will start off with a review of learning objectives, or what we hope you will become familiar with after viewing the training today. Then we will dive into the foundational knowledge portion of the training. This will include background information on Medicare Advantage and DSNPs, a review of the CMS Medicare Advantage plan, and DSNP-specific activities that are part of the Medicare Advantage contracting cycle and application process, and a closer look at Medicare Advantage bid development process. The Why This Matters portion of the training will highlight how Medicare Advantage application, contracting, and bid development processes can both impact and present opportunities for states developing or refining integrated programs. We will conclude by sharing some key takeaways and highlighting where to find additional resources. By the end of this training video, you can expect to become familiar with the key components of the Medicare Advantage annual contracting cycle and bid process, including how this differs from state approaches to contracting with Medicaid managed care organizations, and how the Medicare Advantage contracting cycle and bid process presents opportunities for states to achieve their policy, care delivery, and financial goals, while also imposing some constraints on their ability to do so. Let's dive into our foundational knowledge. The most fundamental principle to understand about dual eligible special needs plans, or DSNPs, is that they are Medicare Advantage plans, and so they operate under the regulations and policies of the Medicare Advantage program. Similar to other Medicare Advantage plans, DSNPs provide coverage for all Medicare benefits, including prescription drugs, for people who choose to enroll. They may offer extra supplemental benefits beyond what the Medicare program traditionally covers. The Centers for Medicare and Medicaid Services, or CMS, is responsible for administering the Medicare Advantage program, which includes contracting with private companies or Medicare Advantage organizations that can apply to offer a wide array of Medicare Advantage plans, including DSNPs. While DSNPs are regulated by CMS at the federal level, they retain flexibility over certain plan features. It's important to note that DSNPs enroll only individuals who are duly eligible for Medicare and Medicaid, unlike non-DSNP Medicare Advantage plans that can enroll both Medicare only and duly eligible individuals. DSNPs are also required to have contracts with the Medicaid agencies in the states in which they operate. However, states are not required to contract with DSNPs, and they may use their contracting authority to add contract requirements that advance Medicare and Medicaid integration. DSNPs must develop and implement a model of care approved by the National Committee on Quality Assurance, also known as the NCQA, that outlines how the DSNP will meet the unique needs of its enrollees. Finally, DSNPs must, at a minimum, coordinate their enrollees' Medicaid benefits. There are a few reasons this training for state officials is focused on developing an understanding of key features of the Medicare Advantage program and DSNPs more specifically. We focus on building states' understanding of Medicare Advantage and more specifically on DSNPs because DSNPs are available in nearly every state, and building knowledge in this area is essential for improving the care of the growing number of DSNP enrollees. We focus on building state capacity because although DSNPs must follow rules set at the federal level, it is states through their Medicaid agency contracts with DSNPs that have significant opportunities to improve care delivery and help advance health equity for duly eligible individuals. As the Centers for Medicare and Medicaid Services promulgates rules and guidance for the Medicare Advantage program, federal Medicare policy is continually evolving. It's important for states to understand the basics and keep up with these changes. As we shift to learning about Medicare Advantage contracting, taking a moment to review a few key components and terminology discussed in this module can be helpful. CMS contracts with Medicare Advantage organizations, including those that offer DSNPs, on an annual basis. The plan benefit period for all new and renewing Medicare Advantage contracts begins on January 1st each year. Medicare Advantage organizations may offer one or several contracts, and contracts can span multiple states or service areas. Each contract has a contract number, which typically begins with H and is followed by a 4-digit number. Medicare Advantage organizations can offer multiple products or plan benefit packages, including DSNPs, under one H contract number. Medicare Advantage organizations follow a well-established timeline set by CMS that governs their application and bid submission process. This is commonly referred to as the Medicare Advantage contracting cycle. Both new and renewing Medicare Advantage organizations must submit a Medicare Advantage application annually to CMS that includes the following information for each plan it offers: a plan benefit package, or PBP, which contains covered benefit and cost sharing information; a bid pricing tool, or BPT, which contains financial projections; actuarial certifications of the financial projections; supporting documentation for both Part C and Part D coverage; a model of care when applicable; and for DSNPs only, an executed state Medicaid agency contract. Applications are submitted via CMS's Health Plan Management System, or HPMS. HPMS is a web-based management system used in the ongoing operation of the Medicare Advantage program. Medicare Advantage bids are at the core of the Medicare Advantage contracting process. The Medicare Advantage bid is a package of materials associated with a Medicare Advantage product offering or plan. It includes plan benefit information and financial projections and is submitted to CMS each year. A Medicare Advantage bid is analogous to other health plan rate filings, such as those rate filings required for plans on the federal health insurance marketplace or those required as part of state Medicaid rate certifications. Unlike most Medicaid managed care programs, the Medicare program does not use a competitive procurement process. Any plan or sponsoring Medicare Advantage organization that submits a bid and complies with all other CMS requirements can contract with CMS. Medicare Advantage organizations are required to submit a separate bid for each plan. CMS sets certain parameters around what constitutes a different plan or product offering, but ultimately, the Medicare Advantage organization has discretion over the number and types of plans offered, how to divide its service area, and the different benefit packages that may apply to each product. For example, a Medicare Advantage organization may offer separate DSNP plans in adjacent counties or separately for full benefit and partial benefit dually eligible individuals. Alternatively, a DSNP may also cover both full benefit and partial benefit dually eligible individuals and/or adjacent counties within a single plan. This matters to states because the Medicare Advantage bid process dictates the timing, federal requirements, and parameters for all Medicare Advantage plans, including DSNPs. Some of the core components of a Medicare Advantage bid are listed on this slide. The bid pricing tool, or the BPT, contains detailed pricing projections and associated actuarial certification. There are various factors such as Medicare Advantage benchmark rates, medical cost trends, and supplemental benefit costs that may impact an actuarial projection. A Medicare Advantage bid also includes a plan benefit package, commonly referred to as a PBP, that contains detailed information about the plan design, including any applicable copays and any supplemental benefits the plan chooses to offer. Bids also include provider network information organized through health system delivery tables, as well as information about Part D prescription drug coverage. This includes the specific drugs covered on the plan's formulary, the formulary tier structure, and any utilization management criteria that will be used by the plan in making coverage decisions. Finally, two important DSNP-specific components, the plan's model of care and its state Medicaid agency contract, are also part of the overall bid submission process. It is helpful for states developing or overseeing integrated programs to understand the key dates and activities that Medicare Advantage organizations navigate in contracting with CMS. So this slide presents an overview of those activities. A well-established timeline set by CMS governs this application, bid submission, and contracting cycle. These federal timelines, especially those related to bid submission, dictate plan decision-making and operations. There are a number of key dates and features of this timeline for states to be aware of. I will highlight a few of those, starting with the November deadline to submit a Notice of Intent to Apply, or NOIA, which serves as the official start of the plan year. CMS requires a NOIA submission for any new Medicare Advantage product or service expansion request. It's helpful for states to understand that the NOIA submission date actually occurs 14 months ahead of when the corresponding Medicare Advantage plan benefit period will begin. To the extent that a state is considering selectively contracting with D-SNPs or aligning Medicaid managed care plans or service areas with D-SNPs, Medicare Advantage organizations generally need to be notified ahead of this deadline. Medicare Advantage organizations have until February to submit their formal application, and any model of care submissions begin in January and run into February. CMS releases the advance notice in February, which provides applicants with high-level benchmark revenue expectations to support bid development, as well as details on any sub-regulatory programmatic changes. Those are finalized in the rate announcement released in April. Different organizations may start their actuarial pricing process at different times, but many start, or at least start in earnest, with the release of the advance notice. Medicare Advantage bids, including the benefit information and pricing projections, are due in early June. This process differs from state contracting approaches with Medicaid managed care plans. Key differences include the rigid deadlines, required calendar year basis, which is shorter than the Medicaid managed care plan contract periods, and the level of discretion provided to Medicare Advantage plans over their specific plan benefit package, cost sharing, and formulary design decisions. CMS releases an updated annual calendar around February each year, and the Integrated Care Resource Center has developed technical assistance tools for states that highlight key dates using that information. CMS's HPMS Resource Center also includes a downloadable calendar for the current calendar application and contracting cycle. So why does this cycle matter to states? First, Medicare Advantage plans, including D-SNPs, need a long runway to implement changes due to the Medicare Advantage bid timelines. And it is broadly helpful for states working on D-SNP contracting strategies to understand early how Medicare Advantage application and contracting timelines and processes differ from those that typically apply in Medicaid managed care programs. At a high level, Medicare Advantage plans, including D-SNPs, are funded through capitated rates set by CMS. Within CMS, the Center for Medicare and the Office of the Actuary collaborate on Medicare Advantage rate setting and Medicare Advantage payment policy more broadly. Payments are based on benchmark rates that are set by CMS and updated each year. Benchmark rates vary by county, but not by plan, and are based entirely on traditional Medicare benefits rather than the benefits chosen by the plan. Payments are adjusted to reflect each plan's star rating and the risk scores of its enrollees. Plans submit bids each year that estimate plan-specific revenue and costs and itemize how they will use the CMS revenue to fund basic benefits, administrative costs, margin, and any supplemental benefits, which may include cost-sharing reductions. Through the bid development process, plans make strategic decisions based on both financial and competitive considerations. It can be helpful to understand the fundamental differences between Medicare Advantage payments and Medicaid rate setting, so I will highlight a few of those differences now. First, Medicare Advantage benchmark rates are based on adjusted traditional or fee-for-service Medicare costs rather than the actual benefits offered or historical managed care experience. Second, the amount of discretion that plans have over plan design and the extent to which that is a competitive consideration is greater in Medicare Advantage. And third, there is potential for significant differences in revenue by plan due to star ratings and risk scores. A separate training video in this series on Medicare Advantage payment policy and rate setting discusses some of these financial mechanics in more detail. Now that we have a foundational understanding of the Medicare Advantage contracting and bid development, let's review why this matters for states contracting with D-SNPs. Understanding the Medicare Advantage bid development and contracting cycle is vital for state Medicaid agencies and their key operating agency partners. This is true whether the state is actively working with D-SNPs to advance integration or just beginning to consider how best to contract with D-SNPs. First, the state Medicaid agency has the ability to partner with and utilize D-SNPs to achieve financial, care delivery, and policy goals. Specific areas of opportunity will depend on a state's landscape, its D-SNP contracting goals, and program design, among other factors. Second, the bid components themselves can be important tools for state information, oversight, and achieving certain policy goals. The bid components can be important for benefit alignment and coordination across Medicare and Medicaid, as well as states exploring financial integration between Medicare and Medicaid. Third, the annual Medicare Advantage contracting cycle dictates D-SNP decision-making and implementation timelines. This is particularly important when states partner with D-SNPs to further integration of materials, benefits, and care management models. The timeline also influences state and plan efforts to build or enhance integrated programs. Medicare Advantage organizations need a long runway to implement changes due to the Medicare Advantage bid timelines and the nature of the annual contracting cycle. States with integrated programs can align their Medicaid contracting cycle with Medicare cycles to promote or simplify enrollment. Now we will cover some of the key takeaways and available resources in the final segment of our training. Some of the key takeaways to keep in mind from today's content include the following. First, DSNPs are Medicare Advantage plans and as such are subject to federal regulation, including sub-regulatory guidance and strict timelines that are part of the Medicare Advantage annual contracting cycle. Differences such as limitation of enrollment to dual eligible beneficiaries and required state Medicaid agency contracts differentiate DSNPs from other Medicare Advantage plans. Second, while DSNPs are regulated at the federal level, plans have latitude over plan designs and other features and decisions that are based on member needs, competitive considerations, and financial position. Third, the bid process and the bid components offer opportunities for states to achieve policy, care delivery, and financial goals for dually eligible enrollees. States developing and overseeing integrated programs need to be aware of the process and key dates each year, as federal timelines dictate plan decision-making. Finally, the ability of a state or their contracted DSNPs to take advantage of the policy or program design opportunities covered in this training can vary by state. This is because there is a relatively wide range of integration approaches and levels of alignment that states may pursue in contracting with DSNPs. Additionally, the Medicare Advantage marketplace varies across states due to Medicare payment policy, competitive dynamics, consumer preferences, the provider landscape, and other factors. Medicaid officials overseeing DSNP contracts should therefore work closely with health plan partners to develop policies and requirements that align with their individual state landscape and goals. There are a number of resources available to states working to integrate care for dually eligible individuals. States can visit the Integrated Care Resource Center, or ICRC, at integratedcareresourcecenter.com to sign up for e-alerts and access a wide array of materials developed specifically for state officials working to improve care for dually eligible individuals. States can request free state technical assistance by emailing icrc@chcs.org. States can also contact the CMS Medicare/Medicaid Coordination Office to learn more or develop new or refined policies in this area. You can learn more at the CMS website listed on this slide. Finally, states can work with the DSNPs operating in their state to learn more about this topic area and consider development of related policies. The information in these slides is provided for educational use of viewers. The views expressed in this presentation are my own and are not the views of Milliman or its global subsidiaries. Please note the other disclaimers and disclosures listed on this slide. Today's training offered foundational information on Medicare Advantage contracting and bid development. We have developed additional Medicare Advantage policy basics training videos in the following topic areas: Medicare Advantage payment policy and rate setting, Medicare Advantage supplemental benefits, and Medicare Advantage star rating system. We hope you will view these additional videos to learn more about the Medicare Advantage program and build on today's content. Thank you for viewing this video about Medicare Advantage contracting and bid development, part of CHCS's Medicare Advantage Policy Basics video series. This video series was produced in partnership with Milliman through CHCS's Medicare Academy, an initiative made possible by Arnold Ventures, the Commonwealth Fund, and the SCAN Foundation. To learn more, view additional videos, and access resources to support integrated care, visit the CHCS website listed on this slide.